I'm going to talk about hereditary GI cancer syndromes, more like an overview, but focusing a little bit more on Lynch syndrome because that's the most common syndrome any one of us will encounter. Also giving a personalized management in the GI cancer per se, but also in Lynch syndrome, and then concluding with the role of primary care provider and non-GI providers in this arena. So what makes or comprises hereditary GI cancer syndromes? So the big chunk of it is still colon cancer syndromes, and they are inherited, and that's the biggest. When we talk about hereditary GI cancer syndrome, a lot of time we are talking about colorectal cancer syndrome. That's the big piece, but there are also other GI organs that can have high risk of cancer, which can be inherited or familial, and that constitutes hereditary pancreatic cancer. And also a small number of patients may carry gene mutation, which contributes to increased risk of gastric cancer, and that is where I'm going to just talk briefly about hereditary gastric cancer. So when we talk about colorectal cancer syndrome, the biggest portion is still of Lynch. And Lynch syndrome is, we all should know about it because it's very common, and it's also sometimes hard to find. So this is, I'm going to focus on that. But when the spectrum we look at, it's really has a lot of polyposis conditions. So FAP is the most common, even though it's uncommon, is the most common in the inherited cancer syndrome arena. Mut-YH polyposis, even more rare ones are hematomatous polyposis. And then there's another class of syndrome which is called serrated polyposis syndrome. And I've question marked it as hereditary because we don't know if it is caused by a gene mutation. And I'm not going to talk about serrated polyposis syndrome, even though I essentially work in this area. We can talk about this at some other time, but this is also a condition which causes and increases risk of colon cancer. So when we look at the epidemiology of colorectal cancer, I've written the year 2000. So 2000 and before, or around that time, this is a very popular pie chart in colon cancer, tells us what causes or what's the etiology. Most of them, 70%, no clue what causes colon cancer. If we test for a known genetic mutation, we won't find it. No family history is usually found in these patients. And then around 30% are the familial, where you have a family history of colon cancer, but if we do a gene test, we won't find anything. So around that time, we thought 5% or so were inherited, and chunk of that was still Lynch syndrome. So around 2 to 3% contributing to the inherited GI cancer or colon cancer syndromes. And a smaller chunk are those rare ones, FAP, hematomatous polyposis. But over the year, more data has come out, and we have explored this further with bigger gene panels. So this is a good study from 2017, which looked at 1,000+ colon cancer. And they looked at a wider gene panel. So not just looking for Lynch or FAP, just looking at a wider gene panel. And they found 10% of colon cancer patients had germline mutation. So we used to think it's around 5, and now the data is suggesting only 10% has germline mutation. 3% is still a constant number for the epidemiology. But what I want to show you here is Lynch and FAP mutation APCs are still there, but there are other gene mutations which are BRCA1 and 2 are high penetrance mutation, not traditionally associated with colon cancer, but was found in these patients. So now we think 10% is the number. So the colon cancer syndrome spectrum, this is just a table I wanted to show. What constitute this, we already discussed what could be the prevalence. So it's very common to very rare or genes, but what I wanted to really show that they require intense surveillance. Early colonoscopy. In FAP patients, we start even as early as age 10. So these patients require frequent, early, and intense surveillance. Is kind of part of their life, focusing just on colon at this point. Now let's talk about Lynch syndrome, because this is the most common, and this is what we should all really know about, and we will encounter in our practice. So what is Lynch syndrome? It is an autosomal dominant condition, and it's caused by mismatch repair gene defect. And the ones listed here, as I show, MLH1, MSH2, MSH6, PMS2 are the mismatch repair. And then there's another gene called EpCAM, which really works with MSH2. It's not a mismatch repair gene, but these are the usual genes we test for. And mismatch repair gene, their role is to fix errors when DNA replicates. So DNA replicates, this naturally causes some errors, and this is their role, to fix it. And when they are mutated, any of these gene mutation can lead to Lynch syndrome. These tumors are also microsatellite unstable, and Lynch increases risk of many cancer, not only colon. What we should all be aware is any colon cancer diagnosed should get universally screened for Lynch syndrome. Irrespective of age or family history, they should all be tested by two methods. And this is what pathologists would do, is check for immune histochemical markers for these mismatch repair genes, or check for microsatellite instability. One or other is okay. And if any of these shows absence of these genes, then they should get germline testing for Lynch syndrome. So this is a universal screening practice, standard of care pretty much in most places. And if it's not being done at any places, they should really be doing this. So colon cancer, along with other organs, but colon cancer should really be done. So why we are focusing on it? And we are focusing because very, very common. 1 in 300 to 1 in 400 could be the prevalence for Lynch syndrome. And more and more data is showing that it is around this number. So this makes it one of the most common in hereditary syndrome. The other tricky part is it's not a polyposis condition. So as a gastroenterologist, when I do colonoscopy on these patients, if I don't have a history that they have Lynch syndrome, or if we don't know they have Lynch syndrome, we can easily miss them, because these patients technically do not always have a ton of polyps, maybe 1 polyps, 2 polyps, no polyps. So this is a condition which has to be identified beyond their endoscopy presentation. 3% of all cancer, but in less than age 50 or young onset cancer, almost 10% comes from Lynch syndrome. So that's young onset cancer. Always think about, could this be Lynch? And this is diagnosed based on family history or personal history of cancer. So the suspicion has to be higher if there is any such history. Colon cancer risk can be very high, and average age is also early in their 40s. But risk of any Lynch cancer can be up to 80%. So what's the worldwide prevalence of Lynch? So this is a recent meta-analysis of 50 plus studies from 18 countries. Granted that many countries are actually not in this map, but what data we have so far from the United States and some from a couple from China and Australia, and mostly from Europe, what they wanted to see is how many colon cancer comes from Lynch, and their overall prevalence they found was 2%. And it varies how you test them. So if you did the usual route of immunohistochemistry and MSI testing and then germline, it was around 2%. But if you didn't go that route and just tested all colon cancer for germline testing, it was higher. But what essentially they found that it is similar for any groups or ethnicity or countries. So it's not that it's high prevalent in Northern America versus other countries. And more countries actually from South America and even India has started bringing up, like they're doing the testing. So we'll have more data in future, but so far we think it doesn't discriminate among the ethnicities. So why we are talking about it, because Lynch is very interesting. It not only increases colon cancer risk, that's what we think, but it increases in organ risk for all these organs listed. And it does not discriminate between genders. So men and women both have a higher risk, and any of these organs potentially can be affected by Lynch syndrome. So it basically reflects how much surveillance these patients may require. The cancer risk also varies depending on the organ. Colon cancer risk is the highest, but I want to tell you about the colon cancer risk. It is also based on mutation subtypes. So MLH1 and MSH2 has higher compared to PMS2 and MSH6 can go down even up to 20% risk. So it varies a little bit based on mutation. And then there are risks for other cancer, other organs, which varies not as high as colon, but they have substantial risk as compared to general population. So What I'm coming down to is Lynch syndrome requires intense surveillance. And I want to show you what kind of surveillance it requires, because not all organs can be surveilled, but many can be. And the number one is colon cancer. And we start as early as age 20, again, based on mutation subtypes. So higher risk mutation, start early. Lower risk mutation, you can possibly decide to start later based on family history. So if there's a family history of colon cancer, then that changes when you started. And screening is quite intense. All the guidelines say 1 to 2 years. No one is saying do it every 1 year or every 2 years. And this is a big question in this arena. Do we do every 1 year, every 2 years? Can we expand it? Can we delay it? So far, it says 1 to 2 years. And then the interval is, of course, decided based on what we find on exam. We need upper endoscopies on these patients because they have risk for stomach cancer, sometimes duodenal cancer, and we look for H. pylori. If we find it, we treat it. And interestingly, this got changed recently when we start screening. So far we were thinking we can delay and start upper endoscopy even by age 40. And this new guideline is really 2 weeks old, where they're saying you could start by age 30, but look at the 30 to 40 range. It's still very wide. So there's data, but not enough to say exactly when we should start screening. So there's still a lot of limitation and knowledge gap in this area. High-risk patients are the one with high-risk mutation, Asian ethnicity, family history, etc. So you tailor the recommendation based on that. Then comes to endometrial and ovarian cancer risk, where essentially the best treatment is once the childbearing is done, you remove the organs. But before that, you still can screen, although screening is not perfect. You can consider transvaginal ultrasound, even endometrial random biopsies, but both are not considered foolproof. It's also debatable we should be doing this or not, or should we just concentrate on symptom-based. At least a pelvic exam is what's recommended every year. And then there are other organs to surveil, and all these organs can be surveilled. Some can be, some cannot be. So like brain, we really don't do any kind of screening. It's just based on annual physical exam. Urothelial based on family history. We can do some urine analysis, or based on family history, sometimes we do a baseline imaging. And again, based on organ and what data we have so far. So that requires many organ surveillance, but also these cancers can creep up if you're not on top of surveillance. So starting surveillance is one thing, but also keeping the surveillance going on is very important in these patients. So 2 of my own patients, I give you an example here. This is a 55-year-old male with Lynch. I think he had MLH1, was normal colonoscopy in 2017. 4 years later, had a 10-centimeter mass in his cecum. So he had no surveillance in between for various reasons. So that really shows that it can happen within 3 to 4 years. And that's why we're still doing such close surveillance. Another very interesting case, a 23-year-old who had normal upper endoscopy, but developed ampullary cancer within 4 years. So again, saying if we know there's a strong family history, personal history, and that we should be surveilling these patients closely. Now, I just want to talk a few slides on the other GI cancer syndromes. The next one is hereditary pancreatic cancer. And there are groups of patients who carries the risk for pancreatic cancer. So 10% of all pancreatic cancer are from hereditary causes. Certain gene mutations, such as Lynch syndrome itself, BRCA1 and 2, Peutz-Jeghers, etc., can carry higher risk with or without family history. And there's some debate going on this, but these patients technically can be screened. The other group is patients who have family history of pancreatic cancer, but it has specific condition. You need 2 family members related to each other, but they may not have any known genetic mutation. And then there's another third group where these patients are hereditary pancreatitis patients carrying certain gene mutation who get screened after a certain number of years or based on their family history. So can you really surveil pancreas? It's not always the easiest organ to surveil, but we can surveil it, and we have been doing it for almost 2 decades now. There's more data coming out. And the way we surveil is we do imaging, MRI, MRCP, or endoscopic ultrasound, which is an upper endoscopy and looking with an ultrasound probe and looking at the pancreas. Now, both the modalities are good, but they are not the best modalities. Both can miss cancer. What we are doing right now, or what's recommended, is we do both, use both in an alternating fashion on an annual basis. And initiating age, say somebody has Lynch syndrome with family history, etc., it depends on what mutation they're carrying. So it varies from age 30 to age 50, really based on case by case. We also do some blood tests like A1C, which is looking for new onset diabetes, could be reflective of pancreatic cancer. One thing I want to say is this should really be done at an expert center, because you're making a patient go through a lot of surveillance with quite intense MRI and also invasive procedure on a yearly and every other year basis. So it should really be thoroughly discussed with your patient, pros and cons, and new data comes out every few years. So all that has to be taken in account if it's really helping the patient, or how we should screen them. There's also possibility of blood markers in future. We have some in research right now, but they're not really ready for clinical prime time. But there is surely some possibility that in future we can hopefully replace or use it as an adjunct to these imaging and endoscopy procedures. Next, just a couple of slides on the third group I talked was hereditary gastric cancer. So the gastric cancer inherited is a very small group, and the bigger one among them is hereditary diffuse gastric cancer, which is around 1 to 3% of all gastric cancer. So this is a separate entity in itself. Other conditions, however, like FAP, Peutz-Jeghers, juvenile polyposis, the polyposis syndrome, Lynch, they themselves carry increased risk of stomach cancer, like I discussed earlier. But hereditary diffuse gastric cancer in itself is a separate entity, which increases gastric cancer risk and is caused by gene mutation, mostly by CDH1. And there's another gene which has smaller contribution to it. But why we talk about it, first of all, it's a diffuse gastric cancer. It's not in one site. It's hard to find. The risk of stomach cancer can be very high, up to 70%. And the way we detect it is based on family history or personal history of more than 2 stomach cancer, or also lobular breast cancer, because CDH1 leads to that. So based on these history that you can detect it, if you cannot, the way to prevent really this cancer is, given how high the risk, if the family history is very typical of many gastric cancer, we usually recommend prophylactic gastrectomy as early as even age 20. But if we cannot do that, or if the family history is atypical, we are not very sure, these patients undergo intense upper endoscopy, sometimes every 6 months, but at least every year, and we take multiple biopsies, so 30, 40, some studies have even shown 60 biopsies to be taken. Even then we can miss these cancers because the surface area of stomach is so high. So this is diffuse gastric cancer. Remember this, if you have family history more than 2 stomach cancer and some breast cancer history, they may have this mutation. So I want to show you how do we identify these patients, GI cancer syndrome patient per se. So one way is, of course, polyposis patients are sometimes easier to get diagnosed because they have lots of polyps. They usually present, if there were no family history known, with bleeding or so, and we do a colonoscopy, and on colonoscopy finds hundreds and thousands of polyps. Diagnosis is more or less obvious. Or if they have family history. Hereditary pancreatic cancer, gastric cancer is really based on personal family history, but there's something to know about pancreatic cancer and even ovarian cancer. These patients should be tested for gene mutation. And that's another way to find out. So if somebody in your practice, you see a patient with ovarian cancer or pancreatic cancer and have not had genetic counseling or testing, they should really be doing that. Or if they are not available, their first degree relatives should be doing it, because they could be carrying Lynch mutation or other gene mutation, which can prevent it may or may not change their management so much, but can really change cascade or family members management. So back to Lynch syndrome, just for one major thing. And the big thing is the prevalence is so high, 1 in 400, that 90%, given that prevalence, we think 90% or more of Lynch patients are not even aware of the diagnosis, because many of these patients carry the gene mutation but never had cancer, luckily, and we don't know when they can have cancer or whether everyone will have cancer. But the question is, we don't know many patients who are actually carrying the gene mutations. For like, if you do a quick math just for DC metro area with 6 million people with 1 in 400 prevalence, that will bring like 10,000 or 15,000 Lynch patients, but that's not how many patients we would have seen here. So it is important to identify these patients by early detection and prevention so that we can, of course, do all those organ surveillance. So how do we identify these patients? Personal history of Lynch-associated cancer. So somebody might get colon cancer, endometrial cancer, which goes through universal screening, even pancreatic cancer, we test for Lynch syndrome. That's one way. The other way is family history. If someone has known Lynch pathogenic variant. But then there are the clinical criteria, which is used if you have suspicion, which is usually in young onset patient with cancer, and they are commonly are Amsterdam or Bethesda criteria. And there's some risk prediction models you can use too, mostly used by genetic counselor. Most common one is PREM5, but there are other more intense ones which can be used. And this is basically putting in the same history of personal family history, and this generates a score. So PREM5 would generate a score, usually a score of more than 2.5, that suggests high suspicion, and these patients should be tested. And Bethesda and Amsterdam criteria is really based on clinical and microsatellite instability. So Amsterdam criteria is based on how many relatives had Lynch-associated cancer and how they're related and if they're young. Revised Bethesda criteria is based on recommending really all these young patients with colon cancer should be tested for microsatellite instability. So these criteria were developed to find these patients with Lynch syndrome. But the problem is no criteria is perfect. So if you use Amsterdam criteria, a number of studies now have shown and that sensitivity is very wide. It can be as low as 50%. A recent study showed a sensitivity of 78%, may have slightly higher specificity. Revised Bethesda, because we are testing microsatellite instability, we're suggesting to test that. Sensitivity was better, but lower specificity. PREM5 or other models can miss BMS2 carriers shown by a recent study. So no criteria is perfect, and that's the problem, that we cannot identify all the patients. So how can we improve identification for hereditary GI cancer syndrome patient, but really for Lynch syndrome patient? So detailed personal family history is still the biggest piece. If we can have a high suspicion, young onset cancer or family history of more than one organ cancer or more than 2 colon cancer in family, those things would really bring the red flag. If you have any such history, have a very low threshold to refer to genetic counseling. Because genetic counselors are the biggest, most valuable resources and team members who sees this patient and does facilitate testing and does post-test analysis. So you should really have a low threshold to send them to genetic counselor or to expert center where they do such testing. Young onset cancer always triggers a flag. Universal screening should be standard, and it is standard at most places. Colon cancer and also endometrial cancer should be tested for Lynch. Then the referral based on endoscopy exam. If you still suspect a few polyps, unusual polyps like bigger adenomas in young patients, does it mean something? We don't have great data in this area, but talking from the GI cancer syndrome, if you see multiple polyps, then of course refer them for genetic counseling. And then multi-gene panel testing is another way to find these patients in colon cancer. And there's question marked here. Should we be doing multi-gene panel testing? That means not just testing for Lynch, doing a wider net and finding maybe Lynch or other mutations. So what's multi-gene testing? Is to test for multiple genes using larger panels. But it's not always based on family history. So it's not only always based, you qualify Amsterdam criteria, so let's do this. It's really figuring out you have colon cancer and let's do the comprehensive panel. So should we perform this in all colon cancer or all GI cancers? That's a question. That question kind of just got answered. This has been in debate for a long time in the genetics world, and I'll show you what changed just 2 weeks ago. So this is a good study of almost 3,000 patients from Mayo Clinic, and they looked at various solid cancer, including colon, breast, other cancers. And they did 80 gene panels. So that was a very big panel of gene. 13% were found to have pathogenic variant, but what was interesting was 6% could have been missed if we had used those only family history or guideline-based criteria, suggesting that also kind of common sense, you do more panel, you are going to find something. This pros and cons debate, should we be doing it for all GI cancer? So the pros is you'll do more, you'll find more, and you can hopefully find actionable pathogenic variant, and that will change the clinical recommendation. It's possibly ease of process too. You don't have to fine tune so much based on family history, everyone gets the gene panel. The cons is you're going to find something called variant of uncertain significance. And this is basically means that at that point, this variant for that gene mutation does not mean clinically anything. So we should, and they are usually tracked on a regular basis, and a lot of them get reclassified into mostly benign, or sometimes they'll have some pathogenic clinical significance. So that has to be really looked into, that more VUSs are being found. Clinical action should not be taken unless and until it's being assessed thoroughly by a genetic counselor, geneticists, or experts in this area. Sometimes, even if you find gene mutation, the clinical management can be restrictive. It may not really change what we are doing so far. And then there's a big question of resources. The more panels we'll do, the more we'll find. Who will do this? Post-test counseling, a lot of education piece to it. But what changed 2 weeks ago, NCCN, which is one of the biggest guideline kind of society, which yearly revises their guideline on various colon cancer and prevention, they're recommending multi-gene panel testing for any patient who is younger, less than age 50, to evaluate for Lynch and other cancer syndrome. But they're also saying if you have no history, I mean, they're older than age 50, or even if they don't suspect that it's Lynch, you can still consider multi-gene panel testing. So this is going to likely change a practice at many places. It will take time. But what we are saying here is any colon cancer patient should not only get tested for Lynch's germline, but wider comprehensive panel. So what's the general process when a patient shows up, when you identify a patient? So technically a patient is identified based on cancer or family history, and then referred to genetic counseling, oncology if they have cancer. And then they get the pre-test, mostly done by genetic counselor, then they facilitate testing. The results come back after a few weeks, and then they do the post-test counseling. And it's really a multidisciplinary kind of recommendations provided. So somebody gets diagnosed with Lynch, and they'll give you a list of recommendations. Now you're at risk for all these organs, and this is all is needed. And it's essentially a one-time visit. And then the patient follows with these multiple providers and teams, and which can be overwhelming for patient and providers. So surveillance recommendation, just wanted to show you, it does not come from one society. There are many societies in play where we tailor recommendation based on what the patient's family history, or sometimes even beyond guidelines. But there are 6 different societies which has recommendation in this space. And the most common, like I said, NCCN, which is also yearly reviewed, but there are other big societies, mostly GI societies, which has these recommendations. So all these recommendations can be tailored in that diagnosis after, say, certain gene mutation carrier. So what I'm getting at is we need a dedicated space for these high-risk patients, because it can be overwhelming with so many recommendations and also changing recommendations. And I want to really take this opportunity to also introduce the clinic. It's establishing here, GI Cancer Prevention Clinic. I've been running for the last few months, where the idea is to see these patients on a regular basis, so we keep an eye on not only what's going on in their GI risk, which can be higher, say, in Lynch, but there's so many other organs, and see if things change and if we can fine tune it. So the benefits of any kind of prevention clinic is that we see this patient on a regular basis, and more for a continued long-term follow-up. So not one-time visit, and then we don't know whether the guidelines change or anything change, and how are they being followed. They also get long-term endoscopy care, and there's a lot of teamwork and coordination of care here. So in our clinic, I see patients combined with genetic counselor, and I've been very lucky to see patients with Dr. Serrano from Pediatric Gastroenterology, which is very, very, I think, rewarding for patient and for us, because we can see these children, say, with juvenile polyposis syndrome or FAP, where we start early screening, but have an approach where we can also say, okay, this is how it's going to happen, how are we going to transition the care. So it's, I think, a very nice piece of multidisciplinary. And also we can see some patient with colorectal surgery where we have to make decision on surgery on especially polyposis condition. The being in one space, we can update them with a recommendation, which changes all the time, and it's confusing with so many recommendations coming out from different society. This helps in avoiding under screening, but also over screening. You don't want to over screen these patients. You have to have the right criteria, guideline, or based on their own personal history. You don't want to just keep screening them. So you have to have a wisdom around it. It's also, we provide recommendation for family members and lifestyle risk factors, which I think we are getting more data, and hopefully more data will come out in Lynch arena too. With this, another big piece is the patients can also take part in research studies and trials, which is essentially missing if we don't know where these patients are. It's very hard to find these patients if there's no one place they come and see. And then again, not all patients fulfill guidelines. So even if you recommend with all guidelines, there will be differences and nuances where the care really becomes personalized. So when I say personalized, we say a patient come in this clinic, we talk about their endoscopy care, but we also talk about other organs and what referrals is required, what has been done, what has changed in this space, and what could be needed. So pancreatic cancer screening, not everyone requires, not indicated for PMS2 mutation in Lynch. There's also a role of chemoprevention in Lynch syndrome, such as aspirin, but we don't know what dose. There's so many things going around chemoprevention. And then annual clinic follow-up is really needed because we need updated personal family history. Family history changes, and it changes recommendation for these patients. The other thing about knowing your patients is we can also offer in expert centers things like Chromoendoscopy. So this is a tool where we use blue dye in patients. This is again my own patient with Lynch syndrome. And if I don't put the arrows, you will not see the polyps. So this was so hard to find this polyp in the right colon. And the only way I found it because I used the blue dye. And so these technology or Chromoendoscopy is not always offered everywhere. It's time-taking, it takes more patience and also availability. So this is something that can be offered. Two examples why we do specific care in these patients. Again, two of my own patients. This is a 42-year-old woman with BRCA2 mutation who was referred for pancreatic cancer screening because she had family history of pancreas cancer. So she has a first degree with age 75, and somehow she got an MRI done, which was normal. And she was scheduled for an endoscopic ultrasound. So like I mentioned, MRI in the US has to be done in an alternate fashion. And she came to see us to discuss more about her BRCA2 mutation and risk of pancreas cancer. But if you look at the guidelines, she actually does not qualify for screening till age 50 or 10 years before family history of pancreas cancer. She was also doing well. The MRI was normal. She had no symptoms. So we actually decided not to go ahead with EUS. It's an invasive procedure, not required till it's required. And then we decided to bring her back in 5 years. So this is an example of avoiding overuse if we really follow these patients thoroughly. Another very good case, I've shown you the picture before. This is a 22-year-old with MLH1 mutation, no symptoms, normal upper endoscopy 4 years ago. And this is the family pedigree. So she has many members with colon cancer, one member with duodenal who underwent Whipple, and then the father had lots of other cancers too. So when you look at just the guideline, does she really qualify for an upper endoscopy? So no one has stomach cancer here, as one person has duodenal cancer. She does not even fit into that age of endoscopy, but we decided to go ahead because she had this duodenal history, family history, and it was just an unusual family with so many cancer occurring, especially her dad has small bowel cancer, so many other cancer. So I decided to do the upper endoscopy, and because she had duodenal cancer, we were not sure it was coming from ampulla. We decided to drop another scope to look at the ampulla, and this is what we found was ampullary cancer. I showed you this example before. So she underwent Whipple. She is completely asymptomatic, doesn't fall into any guidelines, what we know so far, but really based on having the knowledge, a really good knowledge of her family, and had time to explore this so that we were able to find it. So I want to conclude with what is the role of primary care provider in hereditary GI cancer space, syndrome, or Lynch syndrome. So I always say primary care providers, clinic is very, very important because that's where the prevention starts there. And patients are asymptomatic, and I never would see a 20-year-old who's asymptomatic in our clinic, even if they're carrying a gene mutation. So the first place they visit, if they visit, is a primary care clinic, and the way to find is history. So personal and family history should trigger that could this patient have underlying genetic mutation. But there are multiple barriers, right? Time constraint in a primary care clinic, how to really find and get good history. It's very hard to really find. It's easy to say, but when you do this, it's not easy to really find it. So we are trying, and there are other centers, we're trying to incorporate family history into EMR that can bypass and find high-risk patients, and alert referral can be sent to a genetic counselor or so, where these patients can be contacted. In fact, we're starting a small pilot in GI clinic where we want to see if we can find high-risk patients who, just from the family history they provide. So the biggest thing is, if you have a suspicion, you should definitely know your resources. So do you have access to genetic counseling? Do you have access to other specialized resources, expert center? And no question or thing is really a bad question in this. Even if you have a very low suspicion, I think it's worth sending a referral. The role of non-GI providers, this is basically one of my concluding slide, is this is hereditary GI cancer syndrome, especially Lynch syndrome, is a multi-organ disease. So any organ, any system, any patients following they can be diagnosed there. And that's a teamwork. We do coordination of care anyways. So oncologists would say the key, the patients get cancer diagnosis, and a lot of patients do get referred from oncology to genetic counselors, and then kind of find patients through that. GYN cancer, like I said, endometrial cancer, ovarian cancers, they'll see, and they'll also see young patients who have never had cancer for screening and surveillance. Dermatology, there's a risk of skin cancer in sebaceous called Muir syndrome. And I've actually had referral from dermatologists suspicious for Lynch syndrome for patients they found to have sebaceous cancer. Urothelial cancer, patients following in urology, there's guidelines as well coming up, changing in this world in Lynch. And the pathologists are really key partners. So polyp histology, they'll do the immunohistochemistry, finding Lynch syndrome, but there are also some other conditions such as hematomatous polyps, Cowden syndrome, where they can have very specific polyps such as intramucosal lipoma. So even if I do colonoscopy and I find 5 to 10 polyps, and they may or may not be thinking about going to genetic counseling, but if I see this pathology, a pathologist would sometimes trigger and say, this patient should be looked into further. It could have Cowden syndrome. So that's another way to identify. And then surgeons they get a referral for large polyps. Sometimes we find other conditions that this is really serrated polyposis syndrome, or other things that can be found. And even department we're not thinking, sometimes directly related as high risk. So ophthalmology, interestingly, patients with FAP have a very interesting sign called Chorpy sign. Not all patients will have it. It's retinal pigmentation. So if you see this, a lot of ophthalmologists would send referral that they should be evaluated for FAP. So saying that it's any department, any organ system patients following, your patients could be there, and it needs suspicion or the finding to trigger and the referral to be sent. So in summary, to conclude, hereditary GI cancer syndromes can range from very common, which is Lynch syndrome is one of the most common GI cancer syndrome, to very rare conditions, those polyposis condition. Always keep a low threshold for further investigation and referral to genetic counseling or these prevention clinic for any suspicious personal family history of cancer. Early identification and diagnosis really can prevent many cancers. So like I said, more than 90% of Lynch patients don't know they have Lynch, but if we can find them, we can truly prevent cancer. Other thing to know is the widely available genetic testing. Genetic testing has become quite cheap, and it's also available direct to consumer sometimes. So more patients are getting tested. They're also changing recommendations. There's a lot of information on website, like Dr. Google has a lot of information and social media. So more patients will be identified, and more patients will have questions what to do next.